Good morning, all. Looks like people are slowly kind of trickling in. I know for some folks it's noon on the East Coast, so people may be grabbing lunch. For those on the West Coast, it's still morning, so people are kind of grabbing their coffees. I'm going to go ahead and maybe just start some house cleaning rules for those who are already here. And then we'll give our speakers a chance to have as much time as possible here. So I'm going to go ahead and kick this off. I'm Bianca Frogner. I'm a professor at University of Washington in Seattle. I'm part of the leadership team for the award network. I'm also the webinar committee chair. So it's wonderful to have everybody here today. And I want to thank the whole webinar committee for helping to organize this series of events, which happens monthly on typically on the first Wednesdays of each month. This is another installment of our series. The seminar is called Improving Dementia Care for Lower Income Older Adults, Lessons Learned and Opportunities with presenters from Alzheimer's LA. And before we get kicked off, I do again want to remind you that there are future webinars already planned for the months of July and August. So I do encourage you to go visit the Award Network's website at awardnetwork.ucsf.edu, where you can go ahead and register ahead of time for these webinars. A new thing that you will find at the top of that webpage for the webinar portion of the website is a link where we would love to hear from you on ideas that you might have for future speakers. We will also be sending this out via email so that folks can have that link handy and provide their thoughts on other webinars they would like to see. And also, we do record our webinars. We're recording today, so they are available on our website for later viewing if anyone is not able to make it in person. So I'm going to go ahead and, actually, before I turn it over, I do want to mention one other thing is that for those of you who are attending Academy Health's annual research meeting in Seattle, it's taking place June 24th through 27th. And on June 24th, Saturday, at 6 o'clock, we have a interdisciplinary interest group party or reception where we're bringing together the interest groups from the long-term services and supports interest group, the health workforce interest group, and IRGNI, the Interdisciplinary Research Group on Nursing Issues, all together for a reception. And I really want to thank the Award Network for being one of our sponsors of that event. So that also means that you all should certainly think about joining us at that reception. And if you need a link to the invite, we will make sure that we give another reminder out before the event. So just want to make sure we cover some fun stuff too this morning. So with that, I'm going to turn over the hosting duties this morning to Jarman Ye. Jarman is an assistant professor at the Institute for Health and Aging in the Department of Social and Behavioral Sciences at UCSF and one of our wonderful webinar committee members. So Jarman, go ahead and take it away.
Thanks so much, Bianca. I'm so pleased to introduce our speakers for today's webinar. Barbara McClendon and Jennifer Schlesinger join us from the Alzheimer's Los Angeles. Barbara has a deep background in public policy. For almost 20 years, she's focused on aging and long-term care policy and advocacy in her position as the Public Policy Director for Alzheimer's Los Angeles. During this time, she's developed legislation and policy recommendations to improve services and supports for people with dementia and their families. Her current projects include advocating for the development of dementia-capable healthcare delivery systems and building dementia-friendly communities in and around the Los Angeles area through Purposeful Aging Los Angeles. Jennifer is the Vice President of Healthcare Services and Professional Training at Alzheimer's Los Angeles. She oversees technical assistance and support to healthcare systems to improve their dementia capability, manages professional training programs, and conducts outreach to healthcare professionals. Jennifer has directed multiple nationally recognized and award-winning projects, including the Dementia CalMedi Connect project, a project transforming healthcare in the state of California for low-income older adults with dementia, and All's Direct Connect, a program which connects families with dementia to Alzheimer's Los Angeles. Jennifer has spoken locally, nationally, and internationally on dementia-capable healthcare systems, improving care management to meet the needs of families affected by dementia, diversity in dementia, and plain language tools for dementia care. Without further ado, I'd like to turn the mic over to Barbara.
Great, thank you, Jarman. And welcome to all of you this morning. Jennifer and I are going to be speaking to this issue of improving dementia care for lower income older adults, largely through a policy and advocacy lenses. I know many of you here with us this morning, maybe in the research space. I hope that some of what we share today may spark some ideas so that you have maybe some new paths for investigation. With that, we will dive right in. Okay, maybe we'll dive in. There we go. Okay, we're going to start with some level setting. Some of what I'm about to say may be well known to some of you, but we don't want to make any assumptions. So we're going to start at the beginning, which is talking about prevalence. I don't think it comes as a surprise to any of you on this call or on this webinar that the prevalence of dementia is increasing. The number one risk factor for developing dementia is age. So the older our population gets, then the more likelihood of dementia being more prevalent across the community. So currently, 5.8 million Americans are living age 65 and up are living with Alzheimer's or a related dementia. We do expect that to increase really rather dramatically by 2050 to 13.8 million. But things get really interesting when we look specifically into the dually eligible population. And again, just maybe all of you know this, but dually eligible meaning these are people who are eligible both for Medicare, so they are 65 and older, and Medicaid, which here in California we call Medi-Cal. So if you hear Jennifer and I refer to Medi-Cal, it's the Medicaid program that is in all 50 states. So prevalence in the general population of Alzheimer's or a related dementia is a little bit over 10%. But when we look into the dually eligible population, that prevalence rate increases really rather dramatically to 20%. And honestly, we all know that dementia is an underdiagnosed disease. So that 20% is probably a low number. And so why is this? Why do we see more dementia in this particular population? Just as dementia is correlated with age, it also correlates with other chronic health conditions. And many of the individuals who are eligible for both Medicare and Medicaid do come with a wide range of other comorbidities. And so that increases the risk that they are going to have some kind of cognitive impairment on top of those other health issues, hypertension, high cholesterol, many of which may have been poorly managed across their lifespan. Again, people who are living in poverty tend to have more challenging time accessing regular health care. And so all of that comes together to mean that by the time they are in this particular pool, they are more likely to have a cognitive impairment. If I'm a healthcare provider and I get a capitated rate for a beneficiary, which is pretty much mostly the case here in California, I'm highly motivated to try to manage my costs in providing care to that individual. And so we have used that as a leverage point to advocate for change with healthcare plans, because when we talk with them, we make the point that people living with a cognitive impairment are very, very expensive. Really, perhaps the most expensive beneficiaries that they are going to be caring for. And here's the data, the chart to demonstrate that. So patients with dementia cost Medicare 3 times more than other beneficiaries and cost Medicaid 23 times more. And I have to tell you that just keeps going up. When we were first a number of years ago sharing this data, I think it was that Medicaid was 17 times more. So every year people get more expensive, and that Medicaid number that cost is really driven in large part because so many people living with a cognitive impairment end up in a skilled nursing facility, which is far and away the most expensive care setting. And so we use this information again when we're advocating with health plans to say, you know, and we're going to dive into the details of this across our presentation, but there's a lot that they could be doing so they could be perhaps both managing costs better and getting better health outcomes for individuals, hopefully increasing quality of life for those individuals, which is something that we at Alzheimer's Los Angeles really believe in strongly. Just because you are living with a cognitive impairment of some kind doesn't mean that quality of life is not available to you anymore. It may be quite different than how you originally envisioned it, but there is a path there. And so we try to do a lot of advocacy and education to help our systems that are caring for these individuals understand and integrate that as well into their policies and the way they deliver healthcare. This is probably also very much not a surprise to any of you who are with us here this morning, but health inequality, which is a factor across all health issues, is very much in play when we're talking about cognitive impairment. So African Americans, Blacks are 2 times more likely to have Alzheimer's or dementia, far more likely to be diagnosed later in the disease. Again, access to healthcare across the lifespan and a variety of other reasons come into play to explain that, but it's very much a reality that we see when we're working in these communities. Hispanics and Latinos, 1.5 times more likely to develop Alzheimer's or dementia, and again, more likely to be diagnosed later in the disease. With caregivers reporting that they can access fewer formal supports, and so therefore there are much greater demands on them in providing care. And so the impacts on caregivers are, higher rates of depression, issues with their own health care. It is not uncommon for people caring for a loved one with Alzheimer's or dementia to predecease. And it is also, research has shown that people from the African American, Latino communities tend to spend a larger percentage of their family income on providing care to their loved ones. So just a really significant impact on these communities that is a real, something that we very much keep front of mind at Alzheimer's Los Angeles and talk about a lot when we're talking about policy and program development. Jennifer, I believe this is you.
So now that Barbara has kind of set the foundation, I want to jump in, and Barbara and I are going to ping pong back and forth and interrupt each other during this webinar as well to kind of keep it lively and interesting. But I want to talk a little bit about evolution of care here in the state of California, and specifically put a dementia lens on this evolution. So before 2013, health plans were not coordinating medical, behavioral, and non-medical care. And there were no incentives for them to coordinate care. And therefore, there was this inability to truly meet the full array of needs of people. So Medicare is doing its thing, Medi-Cal is doing its thing, our commercial health plans are doing its thing, everyone's doing different things. And certainly there was very little happening in the dementia space. There were no incentives, there are no quality measures for dementia care, no training requirements, staffing requirements around dementia, nothing around screening or caregiver related supports. And certainly not a lot of talk around the social determinants of health and how we needed to be focusing on, again, non-medical issues as well. And then the state of California, for about last 8+ years, embarks on this journey to really coordinate care and to create a system of care that combines both the clinical care needs and long-term services and supports and behavioral health as well. And this, plus capitated payments, paves the way for California in 2013 to launch our duals demonstration, which here in California we called CalMedi Connect. And this pilot served as an opportunity to serve people dually eligible for Medicare and Medi-Cal through managed care health plans. And during CalMedi Connect, there were these wonderful advocacy opportunities and opportunities for stakeholder involvement. And the state did several things that had tremendous impact for dementia specifically, as well as other conditions as well. But again, since we're focusing on dementia here. First, the state adopted a trigger question that was mandated in health risk assessments. So some question around cognition, so that health plans had to assess whether there was something going on with someone cognitively that would then merit further assessment. When we started working with health plans and we were looking at their health risk assessments, I remember working with one health plan and they said, oh, we screen for Alzheimer's dementia. And we said, that's wonderful. We would love to see what tool you're using. And we looked at their screening tool. It was a screening tool for psychosis. It wasn't an Alzheimer's dementia screen. And so we worked with that health plan, but we also worked through state advocacy to say, you know, the state of California needs to have something that's streamlined, and at least one trigger question in the health risk assessment would trigger that process. And so that was adopted and mandated across all the health plans in CalMedi Connect to have that trigger question around cognition. In CalMedi Connect, we also did a lot of advocacy, and that is where we started to have the requirements for dementia care specialists, that health plans were required to have people specifically trained in dementia care and had to have these dementia care specialists, as well as training for these folks. Through CalMedi Connect, there was caregiver identification, and support was written into three-way contracts between CMS, Department of Healthcare Services, and the health plans. And there was also stipulations that the health plans, through their care management, needed to make referrals to community-based organizations for support of families as well. So tremendous change happened within CalMedi Connect, which really moved the needle on dementia care and what these opportunities could afford. But certainly having policy alone and having these mandates did not necessarily operationalize all of those things completely, although the health plans certainly started embarking on that journey to look at what the requirements were and then also to look at how they could operationalize those requirements. Well, California's current Medi-Cal waiver program, CalAIM, affords even greater opportunities to incentivize dementia care and dementia-capable systems. We worked on taking the lessons learned from CalMedi Connect and some of these best practices from CalMedi Connect and ensuring that they were carried over into CalAIM. And in addition to the things that I just spoke about that were in CalMedi Connect and now continue to exist within CalAIM, there's an additional opportunity, which was California adopted for the first time a dementia quality measure for their DSNPs, for their dual special needs plans. And that is the percentage of people 65 and older who have cognition assessed. Also, within CalAIM, there's opportunities for providing beneficiaries with community supports, including things like respite, as well as enhanced care management. And so this really affords opportunities to support the needs of people living with dementia, as well as their caregivers. Running parallel to CalAIM, the Department of Healthcare Services also launched their Dementia Care Aware initiative, which focuses on training and support of primary care providers and primary care teams to increase dementia screening and support. So CalAIM doing a lot in the space of the health plans and care management, whereas Dementia Care Aware is really working more in those primary care provider offices, but clearly the two sync up and there's a lot of synergy between those. And so these two opportunities have really been a window of opportunity for advocates to make the case for dementia capable systems of care and what those opportunities are for greater change in this space. Barbara, if you don't mind going to the next slide. But with all of these incredible opportunities, still exists quality challenges. As Barbara mentioned, detection of people with Alzheimer's disease and related dementia is still poor. It's not done well. We know that only about half of people with the disease get a diagnosis, and of the half that get a diagnosis, only about half of them get it documented in their medical record. We also know that rates of disclosure of the diagnosis are terribly low at about 45%. That it's actually disclosed to them. So a lot of work still needs to be done in that space. There's still limited recognition of a caregiver's role. And we know that caregivers are the backbone of our long-term services and support system. And without identifying who they are and recognizing the tremendous role that they play in maintaining care at home so people can avoid being in nursing homes, that still presents a tremendous challenge. And certainly limited use of home and community-based long-term services and supports to, again, maintain more independence and community-based living. And what's particularly important when we talk about these quality challenges that still exist is we really need to also consider how diverse communities experience these challenges, because these challenges are really experienced by most people dealing with Alzheimer's dementia, but that experience manifests differently and is experienced differently by different communities. And certainly in our communities of color and lower income communities, those things are felt differently and experienced differently as the disease progresses as well. Next slide. And so as we see those prevalence rates and the increase of people living with this disease, and we know that that's going to continue to increase, this puts pressure on our healthcare systems. It certainly puts financial pressure on them, organizational challenges to them. There's workforce competency issues. And we have a fragmented system that increasingly is working to be more coordinated and is increasingly working to bring down the silos between healthcare and community-based organizations. But it's not yet fully equipped to meet the diverse clinical and long-term services and supports needs that our families dealing with Alzheimer's and related dementia certainly experience. And dementia-capable best practices exist, but they are difficult to implement. And certainly our healthcare system, the architecture of our healthcare system is incredibly complex. And so being able to implement dementia-capable best practices is challenging. And we know that health plans and healthcare systems have a lot of competing demands on them as well, which also makes implementation really challenging. So given those, we have looked at we've done literature reviews and consulted with national experts on dementia healthcare. And we have a set of indicators of a dementia-capable system of care. And so I'm going to dive into what these indicators of a dementia-capable system of care include. So the first one is, probably no surprise since I was just alluding to this, is better detection of people, patients or beneficiaries who have dementia. We need to do a better job of identifying and diagnosing this disease. And so this includes everything from having a cognitive impairment trigger question in a health risk assessment or in other assessments that are being used. But after that, ensuring that validated cognitive screening tools are being adopted and are being embedded into systems. And then from there, that there's documentation of the assessment in the electronic medical record. And then from there, there needs to be a follow-up protocol if the cognitive screen is positive, right? It needs to go somewhere, which would be to a PCP, a primary care provider, for them to do a full diagnostic workup if a cognitive screen shows that there may be someone who has issues with cognition. The second indicator of a dementia-capable system of care is better partnerships between the healthcare system and informal caregivers or family caregivers. And so I'm trying to differentiate here the direct care workforce of caregivers and in this particular indicator talk about, family caregivers and families' role in caregiving. And healthcare systems need to be able to identify who is the family caregiver, who is the person that is rolling up their sleeves and providing that day-to-day care, and documenting that information in the chart. We've worked with some healthcare systems who say, yes, we do collect that information, but it is buried so deeply in our record, good luck finding it. And that is not very useful if we're trying to do a better job of managing dementia care. There also needs to be the ability to briefly assess that caregiver's needs. And if we are able to assess them for their needs, then we are better able to support them, whether it's through education or psychosocial support as well, so that we can be integrating them into care teams. We also need to be assigning people who have dementia and have more complexity with their dementia or coexisting conditions to a dementia care specialist, someone who has greater expertise and competency in dementia care management, and the use of standardized evidence-based care plans for dementia care management. And then the third indicator of a dementia-capable system of care is better partnerships between the healthcare system and community-based organizations. And this is really important because community-based organizations are critical to helping our families, and especially in communities of color and lower income communities where there may be a lot of shame and stigma associated with the disease. These relationships, these long-standing trusted relationships that community members have with CBOs really can bring down some of that isolation and some of that stigma to create pathways to provide people with support. And this is, the ability of health plans to adopt a proactive referral tool to connect people to home and community-based services, whether it's respite, support groups, caregiver education, disease education, care counseling. There's an array of services that family caregivers would benefit from tremendously, which would hopefully allow them to sustain the amount of time that a person living with dementia can maintain community-based living. It's also important when we're thinking about our community-based organizations to consider cultural, linguistic, and socioeconomic competency of community-based organizations. Some community-based organizations are deeply embedded in diverse communities, and they have tremendous expertise, and their staff and volunteers share commonalities with the communities they serve and have tremendous lived experience as well that can really help families who might otherwise be treating the Alzheimer's dementia as a very insular issue that they don't want to talk about, they don't want to get support, they don't want to seem that it's shameful, or they have feelings that it means that they're weak, to be able to really work with these families more effectively, to be able to provide them with some proactive and anticipatory guidance and support as well. So as we look at these indicators of a dementia-capable system of care, we want to now share with you some lessons learned and opportunities ahead.
Thanks, Jennifer. Everything that Jennifer just went over is what we have been talking about with the state of California and with the health plans for years now. So, when we see opportunities present themselves to us with the state, the Department of Healthcare Services, which is developing all the policy that undergirds the CalAIM program, or with the health plans that are trying to implement it, we pick out what is of the moment for that, whatever system we're talking to. And we also try to speak to them in the way that in their language, using their language, in the way that they are approaching an issue. And so one lesson that we have learned has really been an evolution across our advocacy, and that is that the state and therefore the health plans that have to implement all of the policy are really moving away from a diagnosis basis for developing policy and more towards function. And this really does make a lot of sense. We have talked about this for years in the advocacy space, how much we share and overlap with the disability community. So we have in the aging community some needs, especially if we're talking about people living with a dementia, that are sort of specific. But there are many issues where we have a lot of similarities, and we can be advocating together, and therefore perhaps more effectively by joining and just focusing on what is the function that individual is trying to carry out in that moment, and so what are the supports they need in order to be able to do that. And so we had to learn that, because if we kept going to the state and saying, we want you to include in the policy guide that if someone has a dementia diagnosis, X, Y, and Z is going to happen, we were not going to get anywhere, because that is not the approach that the state has anymore. We needed to go in and say, look, these are the needs of someone who's living with a dementia. And if you see these needs, then we want them to have access to this range of services.
And what irony in this space, because a dementia diagnosis, by definition, means that the person has functional impairment as well, right? But that just kind of shows the lack of education and awareness around Alzheimer's and dementia, generally speaking.
Exactly. And we really could never forget that one of our most powerful advocacy levers was cost. So if we could talk about our families and these individuals from what their functional needs were, and then always be tying that to, if you don't provide the supports to address their needs, you are going to see these folks in your emergency rooms much more frequently, and you're going to see earlier placement in a skilled nursing facility, which, as I said, is the most expensive care setting that we have in our healthcare system. And so that allowed us to pull together cost and quality and say, if you are meeting their functional needs appropriately, then we can get better quality care for that individual. And then maybe you as the plan, or you as the state, if we're talking, or the federal government, frankly, since we cost share for Medi-Cal, we can maybe do something to sort of contain somewhat some of those costs. So this is rather weedy. I hope we hold all of you here with us today in this conversation, but for Jennifer and I, we love data and we love getting into the nitty-gritty, because there's really a lot of power for change in there. And so if you're familiar with how healthcare systems do their work, you know, there's a code for everything. And so one of the really rich areas for us is to take a look at what are these ICD-10 codes and the diagnosis codes that are in their systems that reflect their beneficiaries. So if you're lucky, you can get a healthcare organization that will run those numbers for you. That is not a given that you are going to be able to get that data. And Jennifer, please feel free to jump in here if you'd like to share the experiences we have had trying to get healthcare systems to do this. But and the data isn't perfect, right? So we know there's underdiagnosis. For example, there might be people who are prescribed medications that clearly seem to indicate that there must be a dementia at play. There is no dementia diagnosis code in their electronic medical record. So we really needed to pull a variety of different data sets in order to see if we could get something of a complete picture of what was happening within that health plan with their beneficiaries. When we've been able to do that, what we have found, I think almost uniformly, is what their data demonstrates as the percentage of people that they care for who have a cognitive impairment is significantly lower than what we know the prevalence data suggests. So we're, instead of seeing data in their system that about 20%, again, because we are talking about, for our conversation today, dually eligible individuals. So instead of seeing data that says about 20% of these individuals are dealing with some kind of an impairment, maybe they've been prescribed a medication that relates to managing cognitive difficulties, that rate might be 4%. Not really anywhere close. And so that tells us that we've got a long way to go to get to accurately diagnosing people who are living with some kind of a cognitive impairment. So function and support, it definitely can be more effective to focus on people with ICD-10 codes who also have 2 or more functional impairments, activities of daily living, poor or no caregiver support, and a need for guided decision making. So again, for us, advocating with the state or advocating with health plans, we are not going to get very far if we just barge in the door and say, everybody that's got a diagnosis of cognitive impairment of any kind, we want them to have access to this higher range of services. Because the truth is, you know, everybody is different, and there may be people who have a diagnosis who maybe don't have other significant health issues and maybe have very robust caregiver support. They may not need enhanced care management or some of the other programs that are available through CalAIM. And so again, we want to make sure that our families get access to the whole range of supportive services that they need, but we need to ask for it in a way that makes sense for the system that we are trying to change. And so our approach has been, okay, if we're seeing someone who's got a cognitive impairment and they have 2 or more functional impairments with their activities of daily living, maybe they are living alone. That is an increasing number of people who are living alone with a cognitive impairment, or they just have very limited caregiver support and they need help making, you know, basic decisions. Some they're still capable of, but with support, then that is a way, perhaps again focusing on function instead of diagnosis, that we can then perhaps get this group of people access to that wider range of supported services under CalAIM. And again, we always come back to tying this to more expensive settings like ER, hospitalization, and placement in skilled nursing facilities. Lesson 2, we need to teach families how to present that person with dementia. We need to teach, this may seem kind of nonsensical, that you would just think, well, don't people just ask for what they need? But they all too often don't, right? So I have heard from my colleagues of experiences where a family wants to get in-home supportive services hours, which is a real challenge to get the amount of hours you need for someone who's living with a cognitive impairment. IHSS historically has really focused on physical impairments more so than cognitive impairments. And so if your loved one is being assessed and before that person has come, you've cleaned the house and you've cleaned them up and, you know, it looks lovely and they may be having a good day, and because you don't want your loved one to be shamed or embarrassed in any way, and now you've presented a picture to this healthcare system that says you don't really need a whole lot, when that may not be remotely the reality that that family is living on a day-to-day basis. And so we need to teach our families how to advocate for what they need, for what their loved one needs, and helping them understand that that is that's not telling private family information in a way that's inappropriate. That is actually advocating in a caring, loving way for the individual with the dementia and your whole family system, so that all of you again can achieve what we know is possible, which is, you know, highest quality of life that is available to that family at that point in the progression of the disease.
And I think what also complicates, you know, this piece is, you know, when you overlay, look, when anyone invites someone into their home, you know, there's that tendency to clean up and we want to present things well. And especially when families are faced with shame around the disease or embarrassment that the person has cognitive issues, or they associate Alzheimer's or dementia with a mental health condition. So there's additional stigma on top of that. And we know that, you know, one of the ways that Alzheimer's manifests is that even as people are in the middle stages of the disease, a lot of times they can still retain their social skills, right? And so someone has been bathed, you know, has been groomed in the morning, so they look very presentable and nice, and they can sit there with a smile on their face and someone can say, how are you doing today? And they nod and say, I'm doing well. You know, someone can say, are you still cooking your meals? And the person, oh, of course I'm still cooking the meals. Yeah, they used the stove and they burned everything, but their ability to smile and nod their head, are you taking your medications? Person can nod and say, yeah, of course I'm taking my medications. Perhaps they're taking them incorrectly. So it's easy to kind of have that image that everything is fine. And, as Barbara said, when we're advocating, it's being honest with what our needs are and not necessarily, painting things over or putting on the rose-colored glasses. But that's very hard for families to swallow, and especially need to consider culturally and linguistically how to have those conversations and advocacy conversations with families.
Because honestly, this is true for every one of us. I know that I have felt this way in my own personal life. I have had to be an advocate for myself with the healthcare system. And so this isn't just specific to our families. And that's also an important message to say, look, this is the way our healthcare system is structured. We all have to advocate for what we need, what we think is in our best interest. And even more important that we do so when our loved one has a cognitive impairment.
I had a great social worker once say, don't explain how things are on the best day. Explain how things are on your worst day. That's what an IHSS worker needs to hear. That's what the doctor needs to hear. We know you have some good days and that's wonderful, but don't explain what a good day looks like. That's not going to get you what you need. Explain what your bad days look like, because that's probably more indicative of what most days are feeling like and looking like too.
So shifting back to the systems that we're trying to change, with lesson learned number 3, quality indicators can drive change. These health plans, I really have tremendous sympathy for them, because what they're being asked to do under CalAIM is work in a way they have never worked before. They have never had to be concerned before about housing, for example. Someone can be discharged from a hospital, you give them a list of local resources and you say, good luck with that. You can't do that anymore under CalAIM. You have to have conversations about, well, where are you going to and what does your housing look like? So they really are stepping out and having to build capacity and knowledge in areas that they've never had to do it before, right? So they're basically drinking from a fire hose every day. In that kind of environment, it can be hard to get their attention to our families, right? We're like, I'm trying to figure out the housing over here. I don't know what to do with the families who have a loved one with cognitive impairment. Well, one of the ways that you can focus their attention is if there is a quality indicator that they are going to be measured by the state in your space. And so we are very fortunate to really have excellent partners within the state's Department of Healthcare Services. I mean, we've worked with these folks for many, many years. And I think the combination of just being excellent partners with one another, really genuinely trying to help each other do a better job, has put us in this space where we can have really productive conversations with Department of Healthcare Services staff about how can we drive change. And so as a result of that, we were able to put in place the very first quality indicator related to cognitive impairment. And it is this measure of the percentage of people 65 plus who've had cognition assessed. Now, that word assessed means different things to different systems and different people. So it's not like, oh, we have a quality measure, our work is done, because now it's conversations about, well, what do you mean by assessed? This is what we think assessed means. And then what do the health plans think assessed means? So honestly, the work kind of never ends. We need to constantly be refining that. And, what are we measuring? And we haven't even, this is a new quality measure. We're not going to get the data for it, I don't think, Jennifer, until next summer. And we're a little concerned already about what the quality of that data is going to be. And so, again, this is probably going to be iterative. What kind of guidance does the state need to be giving to these health plans? What are the systems that need to be in place within the health plans to actually get this data? And I will also say, again, theoretically, the answer to the question of what percentage of people over 65 have cognition assessed is 100%. Because if you are a Medicare covered by Medicare, your annual wellness exam is supposed to include a cognitive assessment. We know it doesn't most of the time. So that percentage, whenever we start to get that data, is not going to be 100%. And so that gives us a lot of opportunity to look into what's happening that is preventing that number from being what we know it needs to be? What are the incentives that we might be able to put in place to get us to that space where everybody actually is getting at least a very brief cognitive assessment every year? What are the workflows and processes that need to be in place to support that? So Department of Healthcare Services does have a template for annual reporting, but again, we anticipate challenges arising for the health plans and the data that they are going to report. And again, this isn't where we stop. It's not as if this one quality indicator tells us everything, even if this one was perfect, even if we all agreed on the definition of assess and the healthcare plans were gathering data in a way that was easily reportable and giving us what we wanted for this. There are other quality measures that we hope to see as we move forward with rolling out CalAIM. For example, if we've assessed everybody, well, what happens after that? Who actually gets diagnosed? And again, back to those diagnosis numbers match the prevalence numbers that we know that we should be seeing in this population. So a lot of room for additional work in this space. Lesson learned number 4, we need to advocate for problems for which we can provide the solutions. Ideally, that is absolutely the case because, again, as I said, these health plans are overwhelmed right now. I think if you are working in any way in the healthcare space, whether that's as a researcher, as a practitioner, this is a very complicated, challenging space to be doing this kind of work. And so we are most effective with our advocacy when we can go in and say, hey, we would like to see better care navigation for our families. And we think you can get to that if you are using your dementia care specialist properly, because that was a whole nother issue. And Jennifer, you're welcome to jump in and speak to this. What you found in working with health plans was they were all using them differently. And in some cases, in ways we had not anticipated. And then, let's provide some training. Let's how are we using them? Let's provide the training so that they can then help these families navigate this progression of the disease. Because this is the thing with Alzheimer's and dementia, these are progressive diseases. So where someone is at one moment, 6 months later, a year later, things could look quite differently. And so you need to have that constant touch base. What is happening now? What needs adjusting? And so care navigation for people living with a cognitive impairment is absolutely essential. Again, if we are going to manage their care and try again to keep them in the setting that they would like to be in, which is almost always in their community, in their own homes if possible. And again, trying to help both the person living with a cognitive impairment and their caregivers have best quality of life that is possible. And I'm watching the clock here, and I know that we want to leave some time for questions. So I'm gonna move us forward here. So lesson learned number 5, that community-based organizations have expanded opportunities to be part of the healthcare system. This has been a really, really exciting change over the last 3 or 4 years. It's because the healthcare system, which used to be pretty locked down, kind of like, we've got our thing, this is our space, we don't need you in it. And if they happen to find you out there in the community after they've left our space, well, that's great, but that's really not our concern. Now the whole system is getting so much more integrated, and the state is coming to community-based organizations and saying, we want you to have a formal role in this healthcare delivery system. Jennifer, do you?
No, I was going to say, it lists here some of those opportunities. I think one of those too, which isn't specifically called out, but is the opportunities for CBOs to be part of enhanced care management. And, that has been called quite recently a once in a generational opportunity for community-based organizations to be truly integrated into the model of care. And so there's some just enormous opportunities right now that are in front of CBOs to be part of the healthcare system. But with that presents some tremendous challenges. And Barbara, if I'll just continue since I'm talking about this, but there's challenges around data, getting access to data from healthcare organizations so that interventions can truly be most impactful. Business partnerships community-based organizations traditionally have not been HIPAA compliant because they haven't been delivering healthcare or medical care, and then this need to become HIPAA compliant. Looking at IT platforms that are used by CBOs are likely not going to be compatible with the IT systems that healthcare systems have. The geographic coverage, health plans, some of them are national, some of them are in a particular state or are in a particular geographic area, and a CBO, I look at our organization, we focus on Los Angeles. So our geographic coverage may be more limited than a healthcare organization. And so there's some wonderful opportunities, but there's some real challenges. And I think, one of my more recent conversations with a health plan partner that really made me chuckle is I said something about, here at Alzheimer's LA, we're a small nonprofit and we're nimble and we can work with you. And my healthcare partners immediately said, and we are the exact opposite of that. And I said, yes, I've been working with you for a very long time. And I know health plans are not nimble and everything has to go through legal and compliance and the Department of Healthcare Services. And so this wonderful partnership is great, but there's a lot of disparity in that partnership. CBOs are a little fish in a very big pond. And so great opportunities, but great challenges as well in that space.
Two more lessons that we want to share with you this morning. This one is timing is key to success. So we have absolutely learned that there are moments when the state is focused on one particular area, and if we're trying to get them to focus somewhere else and make a different kind of a change or implement a new program or whatever's asking for, we are not going to get anywhere because this is what they need to be focused on. This is where their deadlines are. And so that's the space that we need to be working in. So for example, if we want to get the state to adopt a new community support, so this is the range of services, respites included in here, a lot of housing supports, transitional supportive services that are optional services that a healthcare plan can offer its beneficiaries. If we would like to add to that, we need to know that the state can't add a community support without going back and getting approval of the waiver. And so they're not going to do that in the middle of when, the time frame when their waiver has been approved and they're just on implementation. But there will come a time when the waiver is up for renewal. Now, this is the moment when we can really go to them and say, hey, there's some changes we'd like to see. Would you consider including these in your revised program that you're going to be asking for the renewed approval from the federal government?
And this timing, and this will parlay into number 7 too, is even though we have to understand when there are opportunities and where the focus of our health plan partners are, is our ability to cultivate relationships with champions in health plans is crucial to success, because those champions, those people who have a connection to the cause, they carry things forward. And so it may not be an opportunity at this moment, but as we cultivate those relationships, those opportunities do open up. And that takes us to 7.
Have a long-term perspective. As Jennifer said, health plans are not nimble. The state is not nimble, though it tries hard. Change happens slowly. You have to be in this for the long haul. And so that is what we have done at Alzheimer's Los Angeles, is we've been doing this now for many years. We absolutely have a parking lot of ideas. And so when opportunities present themselves, we go there and pull them forward and try to see what we can make happen. Keep building on relationships. And as you've been saying, be strategic and timely with our asks. And with that, I think we are at questions. I'm going to stop sharing my screen and turn it to you, John.
Yeah, thank you so much for that excellent presentation, just presenting such great insights from the policy advocacy and practice perspective on the ground. I think it really is like pushing a boulder uphill with lots of complexities, inconsistencies, and paradoxes all along the way. I welcome attendees to please type questions into the question box. And while folks work on that, I can maybe kick us off with one question. And I just wanted to ask, it seems like many of us are academic researchers, and our knowledge is only as good as the data we have to work with. And it certainly seems like there's a lot of inconsistencies and gaps and imperfections in particularly the administrative data that we're looking at. But from your perspective, where could academic researchers play a role in some of the broader work that you're doing, and maybe specifically around data collection and knowledge production?
Do you want to take that, Jennifer? Or do you want me to?
Well, I mean, I can start by saying, a lot of the work we're doing, and especially when we have pilots, we are looking for our academic partners to partner with us to be able to do some of the evaluation of those pilots, of those projects, which helps strengthen the data and brings a level of rigor to the work that we're doing. It's nice to say that, the programs we have improve quality of life, but let's get measures in place to show that it actually improves quality of life, or, that we actually have an impact on healthcare utilization. And so there's certainly a role for, academic partners to be able to work with community-based organizations like us to be able to evaluate the programs that we're doing.
I also think that there's value in assessing data and pointing out where it is limited, where it isn't what we need it to be. I mean, so I've been in rooms where people are presenting data and like, wow, those graphics look really cool, but you have not accounted for the fact that dementia is underdiagnosed. So fundamentally, don't we have an issue with the data that you just showed me? Pull that forward. Just put that right up front, saying, okay, this is the data we're talking about today, but we need to understand these caveats to the data. And then you may be able to help us push for the changes that we need inside these systems so that we can have improved data.
And, Barbara, it makes me think about all of the dashboards that DHCS has, right? So much data is presented, but how do we scrutinize that data? Right. And I think we really could look to our academic partners to help us have that lens on that data that DHCS provides.
I have a question, and I realize as a panelist, I can't actually enter that into the Q&A. And so it's a wonderful presentation, Jennifer and Barbara. I'm on that point of data. I just was wondering when patients do come in to a visit, they're not re-diagnosed with Alzheimer's each time. So I'm recognizing that when you're looking to find an Alzheimer's diagnosis, you have to look back through records, right? And so I realize, at least from the claims side of things, so not the EHR side, but researchers oftentimes are using claims to identify people with Alzheimer's. They have to find that one visit where someone was diagnosed, right? Because there's no other requirement for someone to be diagnosed each time that they go in with Alzheimer's, right?
No, and like I said, you might not even see a diagnosis. And so now you need to look at what medications they've been prescribed. Because maybe there's an Aricept prescription in there, and you're like, wait, why is there an Aricept prescription for this individual when there's no diagnosis that I can see anywhere? We don't have time. Obviously, we're almost out of time to talk about why doctors don't diagnose or tell families about diagnoses. But yeah, it's an issue. It's a problem.
Yeah. So I know we're at time, and I really appreciate you both giving such a wonderful presentation. Lots of food for thought. I have so many other questions too, so I'm hoping that folks might reach out to you afterwards with questions. And thank you, Jarman, for hosting, and thank you everyone for coming today. Thank you.
Thanks so much.
Take care.
Bye.
Bye.